This is my second time with all of you, and it's always such a special moment. We work with a lot of partners in this state, and nobody more important than the whole care management teams. So we're happy to bring you some of the newest information we have on healthcare planning and where it's going and how you can use it. And there's a lot of great tools here tonight. And I want you to first know that everything we talk about tonight will be on the Honoring Choices website. So there's quite a few pieces of information, some great tools, and I just want you to know it's there for you. So I'm going to go ahead and share my screen and we can get started. There we go. I hope everyone can see that. So for those of you who don't know, Honoring Choices is actually a consumer-based organization. We've been now around, we're just celebrating our 8th year. I'm a guardianship attorney by trade, and I actually closed my law practice to start Honoring Choices Massachusetts because I realized that people in the state just really didn't have a good sense of their right to direct their own healthcare choices, and didn't actually even know how to find a healthcare proxy. We all think we have to go to attorneys, and that's not true. And we're going to tell you a little bit about the work that we do. And what we hope to offer you tonight is a whole set of tools and information so that you can help adults in your community start seamless planning conversations, ones that start very simply and progress to serious illness. And again, I will take some breaks during this because it's a lot of information, and I'll be happy to answer your questions as we go. Okay. So our objectives tonight is just to, again, how do we engage adults in these seamless conversations? We're going to introduce to you the art of a simple conversation using the Getting Started Toolkit. That's the Honoring Choices Toolkit. It comes in multilingual forms. And we're also going to talk about other New England planning documents. And then if you're talking with a patient who is really starting to move into serious illness, we're going to have a what matters most conversation, something that Emily just referred to as well. They do so well at Hebrew Senior Life. And we're going to introduce the Ariadne Lab Serious Illness Conversation Guide to you. I want to tell you a little bit about what's happening in Massachusetts with the eMost web portal and some exciting news on a whole new post process and a post registry for the very first time tonight. And of course, this is all based on the principles of respecting patient rights and their dignity, and helping you to be able to do that job as you face those ethical challenges, especially with our culturally diverse populations. So a little bit about Honoring Choices. It's as simple as this. You know, we like to say to folks, it's your healthcare and it's your choice, that everybody wants to get the best possible care that honors their choices at every phase of health. So our job here is to empower and inform both consumers and care providers in working together to make a healthcare plan. And then we work with hundreds of partners throughout the state to help people connect to care in their community. So as we think about proactive planning discussions at every phase of health, the way we look at this is that everybody's on this healthcare journey and everybody wants the best possible care, whether we're promoting everyday wellness, whether people are managing their health needs and chronic illness, or just living well with serious illness. And in order to do that, we just think everybody needs to make a healthcare plan. We call it healthcare planning here because it's not about just advanced care planning, which is really this smaller segment of documents that tend to get focused on when we're sick. But we want people to think about, what do they want throughout their whole lifetime? You know, how do you get good care all through your life, not just at the end of life? And it's really never been more important with COVID to help people make a healthcare plan. Still, even a year into COVID, our people are really understanding that writing down what they want in case they get sick is just so important. So it's one of the things we'll walk you through tonight. And in Massachusetts and everywhere else in the country, you know, everybody has a right to make their own healthcare choices. So having a plan protects you, it protects your family, supports your family in knowing how to care for you if you can't speak to them. And it certainly helps you as healthcare providers. So at Honoring Choices, we just, again, I work through the law, and the law can be a great equalizer. And we definitely see that in helping people make a plan to get quality care. So Honoring Choices has an easy to use, structured approach to healthcare planning. And again, it's for both of consumers and care providers. We found when we started 8 years ago, there were so many terms. What's an advance directive? What's a proxy? What's a living will? That people were really, truly confused. We don't make this all that easy in Massachusetts. So we're trying to bring all of that together to make a simple kit. And what we say to folks is, just even before you pick up a document, let's just talk a little bit about what you understand about your healthcare and where you are on that journey. Well, what are you worried about? What are you facing right now? What information do you need in order to make informed decisions? And when you start to be able to understand that and make choices, that's when we go to that planning stage and we think about what's in that plan. So in our state, there are 5 documents which we'll run through tonight. Every state has its own law and its own documents, so we want to say that right up front. And if it's not the Massachusetts documents, we'll show you the New England documents, but if you're outside of those, we just go to your services, to your local legal services to see what documents you use in your state. So again, the plan is to think about what you want, make a plan, and then the big piece here is to help people feel empowered with those documents to go have conversations with you, with care providers, to say, not only like, here's my healthcare proxy, but let's talk about my care. Let's talk about how I'm feeling today, so that I know how you're doing today. We know what's coming down the lane for you, so we can know and honor your choices. That's the general model that we use. And we put it all together in a program called Who's Your Agent? Because that's where we like to start here in Massachusetts. Anybody 18 and above, anybody who's considered an adult, can start to make their own plan. And what we've done in our program is made 2 easy to use toolkits, the Getting Started Toolkit and the Next Steps Toolkit. And we find that this really opens the door to lifelong healthcare planning. So we're not just doing one document and putting it away, but we're starting a lifelong conversation with our care providers or with our patients or residents to be able to keep talking about planning. So in Massachusetts, this is the 5 Massachusetts planning documents, and this is how they work inside the toolkits to make it really easy for you. So to have those simple conversations, we have the Getting Started Toolkit. And in that kit, which we will explore tonight in depth, you'll see a healthcare proxy and a personal directive or a living will. Most of you, I'm sure, do this work all the time, but the healthcare proxy does one thing, right? It just appoints somebody to be your healthcare agent. You're giving somebody the power to make decisions for you. But that's all that document does. So in this state, in order to then tell your agent what you want for care, we need to write that down in a different document. And what we call, it's anything that's called a living will in Massachusetts, but what Honoring Choices has done is made it simple. We call it a personal directive. We've made our own, and you can use that. Since it's a personal document, it's not a legal document, anybody can use it. So if you help people do these 2 pieces, these 2 planning documents, boy, you've done a lot. They've chosen an agent and they've told that agent what they want for care. So it's been a very well received and very popular toolkit throughout the state. And the Next Steps Toolkit then takes the next 3 planning documents, and you're really looking at that next step in life. So the question is, now that I've started my plan and started to talk about what I want for care, how do I build on that? And we, especially for our seniors, money is the next concern after their health care. How do I protect my money? How can I be sure if I become unable to make decisions, my money is safe and someone's going to be able to help me get the care that I need? That gets done in this state in a durable power of attorney. So information about that is on the website. And again, it's just part of this plan. And we find that especially our seniors ask a lot about this. So we want you to have that information. The last two documents in Massachusetts are medical orders. They're not legal, they're not personal, they're medical. And one I'm sure you're familiar with is the Comfort Care Do Not Resuscitate order. And that's an order for people who are seriously ill, where they sit down with their physicians and their clinicians and sometimes all of you, depending on the care teams that you're part of, to say, if my heartbeat and breathing stop tomorrow, I don't want to be resuscitated. That's all that order does, is that one thing. And about 10 years ago, MOLST came into the state, and that's called Medical Orders for Life-Sustaining Treatment. And that takes that CPR decision, that decision to intubate, to revive or not, and puts it in the MOLST form. And then it adds more decisions, life-sustaining treatment decisions. So the first one is about, do I want CPR or not? The second one is, do I want to have ventilation or not? And the third decision is, do I want to be transferred to a hospital or not? So that's just to give you a simplified form of simplified information on what's on that form. There's much more information on our website. We find most people know about it. I'm assuming at least a good amount of you actually use it. But it's interesting that some people just don't. They haven't, crossed it into it and given their work. But those are the 5 documents in Massachusetts. That's what we use to make a plan. It's completely voluntary. You can decide to use these documents or not, but it is one way to really communicate your decisions for care. So as I said, we also work in New England. I know we have a few people here from New Hampshire and Maine, maybe other places, but if you want to substitute anything we talked about tonight with your state's documents, they're right there on our website. You just go to the New England page and the documents will be right there for you. So let's talk a little bit about the Getting Started Toolkit. This is the simple conversation. This is the one that our partners do, and they can start a conversation, they tell me, within 5 minutes. And if people actually know who their agent is, it's a very quick process to help them fill out a healthcare proxy. As I say, you don't need a lawyer. We can do this ourselves, and this kit is made as a do-it-yourself toolkit. However, we find it really helps to have our providers and be able to help people with this. So it's a 1, 2, 3. If people can, choose a healthcare agent and a healthcare proxy. Not everybody can, as you know, but if they can, that's a great first step. We saw in COVID how important this healthcare proxy was. It was the one document that was able to connect a patient who was very sick to their agent who was not in the hospital or in the nursing facility, couldn't come in. So that document became really essential in the last year. So you choose an agent, and then the second step is to write down those choices in a personal directive and talk to your family and friends about that. And the third step is this important one, which we work hard at now, which is to empower folks to say, okay, great, I made some choices. Let me get to my care providers, make sure my documents go in my medical record. And also it opens up these conversations just about goals of care. And that's what's been the most wonderful thing in the last 8 years, is to watch how these documents, which were considered to be in your drawer and pretty dusty, how they've been brought back to life to be active, living documents where you can start conversations around that. So in Massachusetts, the law makes this kind of easy. Believe it or not, in the law, it says the person you choose is your healthcare agent. And that's why we call it an agent. Because again, we're trying to get everyone lined up under the law, so our language and what we do for folks tends to be more equitable. So your person's your agent, and the legal document is the proxy. So what that means is we invite everyone then in step 1 to choose a healthcare agent by starting with a really simple question, by saying, do you have an agent? And what we've trained hundreds of care providers in this method, and what they like about it is that it takes people by surprise for a second when you say, do you have an agent? And it gives you the opportunity to say, well, let me tell you what that is. That your agent is your advocate. That's a person you choose, someone you trust, who can make decisions for you when you're unable to do that for yourself. So that person you trust, your healthcare agent, now has the power, the legal power, actually to step in and to make care decisions for you and get you the care you want. And we like to make the point to people that, sometimes you just get sick for a few days, and you're in a hospital and you really want somebody there to be your advocate and speak for you while you recover and while you get better. And we have found that if we actually couch it that way and not just that you're terminally ill, that really helps people see the value in having an agent. So in Massachusetts, in this state, we're a little different, with most things, but in this state, we must appoint. In other states, we don't have to, but in this state, your spouse or your family member doesn't automatically have that legal power. We don't have that default surrogacy law here that says anybody can step up in your family and make decisions for you. They really can't have that legal power unless they're appointed in the proxy. So just to explain that, typically if someone's in a hospital in a hospital and someone is not able to speak for themselves, they're incapacitated, they're sick, and the physicians will go to the family who's in the room and say, here's our plan of care, here's our treatment, does everybody agree? And if everybody agrees, they move forward, right? We don't want to end up in court every day. But what happens if two family members don't agree? A husband says one thing, the adult son says something else, the sister from California flies in and says a third thing, then you have a problem because none of those people have been appointed that person's legal agent. And that I'm sure you've all encountered as a problem. And we find consumers don't know this. They don't know that they must appoint. So letting them know that law has helped people actually get these proxies done. I'm going to go through a few more slides about the proxy, but I'm happy to take questions about that in just a few minutes. So if you want to type them into the Q&A, that'd be great. So as you may know, and just in case you don't, but I assume most people know how to do this. Who can be an agent? Anybody. Anybody who's 18 and above and has capacity. So we often invite you to, when you're talking to people about do you have an agent, to go beyond the family, to say, are there friends? Are there neighbors? Is there someone you would trust to be your agent? Anybody can do that, but not a person who works at the place where you're a patient unless that person is related to you. What's an agent do? It's an awesome power a healthcare agent has in this state. Although it is a big power, the agent is directed under law to make decisions that you want and not always what the agent wants. There could be a difference of opinion, but their first job is to say, I know what my person wants, and I'm going to do my best to get them that kind of care. So an agent can step in to talk to the clinicians, to discuss illnesses, treatment options. They get to look at the medical records and the tests, and talk to clinicians and you about those choices to get people care. And an agent steps back, as soon as somebody has the capacity to make decisions for themselves. So somebody comes in with a UTI and they're a urinary infection and they're confused, they're not able to make decisions, but we know that's temporary. And as soon as they're able to do that, they get their power back to make decisions. In the toolkit, the Getting Started toolkit that I believe you have, and if not, we'll make sure you do, there's a downloadable sheet for you to say what an agent does. This is all you have to know about someone being an agent. If it goes beyond this scope, then it's a legal question, and it goes to a lawyer somewhere. But this should give you everything you need to know about how to choose an agent and what an agent does. We also have a form in the kit about how to fill out that healthcare proxy, which we're going to talk about in just a minute. So let me just show you the proxy and then we'll stop and answer some questions. But if you need this, we have free healthcare proxy up for people to download. It's been downloaded widely throughout the state, works really well. We also have it in 10 languages, which again has been absolutely essential, especially during COVID, to be able to offer people something in their own language. Some of the people we work with we train people as healthcare planning ambassadors. So they see that some of the slides you see tonight, we do it a little more in-depthly so that they feel really comfortable. We work a lot with bilingual ambassadors, care providers, just like yourself, to be able to present more culturally competent conversations. And we're hoping this year to even up that game so that we're working with more people who can do clinical diagnosis and prognosis to give a clinically and culturally competent conversation, because often we don't have that person or that time to go through those discussions more in depthly. So that's on our radar. If you'd like to join us with that, if you are able to do that, we'd love to bring you in here as a healthcare planning ambassador. It's free, and it's just to be able to say that there are people out there doing this work. So all of those documents are free and online. Okay, as you can see, the proxy is pretty straightforward. All people really need to have before they get started is the name of their healthcare agent, right? An alternative agent if they can, but it's optional. We've found, especially in working with seniors, that it's really difficult to find one person to be your agent. It's near impossible to find two. So that's okay. That shouldn't stop them from being able to do a valid healthcare proxy. And you're going to need 2 witnesses, right? And that's been the trick during COVID. It's getting better now. But a witness is anybody who is 18 and older. It just can't be your healthcare agent or your alternative agent. So you can't be a witness and an agent at the same time. And very simply, a witness watches you sign this form. They take the pen, or probably a new pen during COVID, and they sign their name right after you, and you have a valid healthcare proxy. So I'm going to stop, and I'm going to ask, I see some questions coming in, and ask either Anita or Mary maybe to help me with those questions.
Sure. You have 3 questions here.
Okay.
The first one is, many times people may have no close family or friends, or dynamics are not conducive to easily identified. In those circumstances, what have been some alternatives?
And this is, I assume this means for an agent that people just don't
Correct.
have people for that. Yeah, and this happens all the time. What our partners are telling us, and again, those are the healthcare providers that we work with, who take our tools and use them and have these conversations. They think it's about 1/3 of the people actually can identify an agent. So many reasons why that's true. So we're going to tell you about that in the next step, actually. What do you do if people can't identify an agent? And the simple answer is we go right to step 2, and we go right to the personal directive. And if you can hold on, I'll tell you about that in just a minute.
The second one is, what if your healthcare agent is a neighbor or friend who happens to work at the place where you become a patient?
Okay, well, that's a little tricky. So I have to give you a general answer here, because sometimes it's really up to the place you work. They have policies and procedures about that. Now, generally, if that person is working there, but is not in charge of your care in any way, then there would be, and there's no place there could be a conflict of interest, then it's probably okay. But I have to couch that in saying that what we've learned is, even though I can give you the law tonight, it really has to interface with the policies and procedures of your individual facility.
And the last question here is, in some states, impaired cognition requires some specific written authorizations to enact healthcare proxy status. Can you talk about that and how that might be addressed in Mass versus those states who have required language?
Yeah, great questions, all of them. So again, I'm going to give you some general information here. Mary, could you keep that up so that I can keep looking at
Sure.
that? If it went away, because I want to make sure I answer it right. Yeah, I lose it fast this time of night. But I think it's about, sorry, you're going to have to show.
Oh, it's under the answer. Some states, impaired cognition requires some specific written authorizations to enact.
Okay. So here's the way it works in Massachusetts. We don't have any specific authorization by law that has to be done to invoke that proxy. Okay, it's a little loose in this state, which is, good and bad. But here's the way it's supposed to work that protects people. Being an agent, if someone is incapacitated, the only way we know that is through a medical determination. We can't have somebody's agent say, oh, my mom is really not good. She doesn't remember things, so I'm her agent and I'm stepping up. That's not the way it's supposed to work. Mom has to have a medical determination and it had that she no longer has capacity. And under the law in Massachusetts, it has to be written in the medical chart that that is true. And that's a safeguard for this. We understand that that doesn't always happen in practice. But if you're advocating for someone, that is something you can look for and ask for. Did I get the whole question there?
I believe you did. And there's just one more, and it's more a comment, I think, than a question. Date of birth is very important due to duplicate names when filed on hospital records.
Absolutely true. And actually, the healthcare proxy that we give out to our hospitals and our nursing facilities include the date of birth. The thing about the date of birth is it's not mandatory under law, so some people don't require it. Some hospitals and facilities look for social security numbers, and we're not going to put that on this form either. So we're aware of that, but that's a great comment. Dated in all spots. I see that. Yes, absolutely true. We have to fill these forms out completely or they can be challenged. So we do have to make sure they're dated in all spots. Great. Thank you for those comments and questions. Anything else we see?
Ellen, I see one in the chat.
Okay.
What are the rules for same-sex partners or non-married couple as far as a proxy goes?
As far as a proxy goes, so we'll go back to the idea that you are allowed to choose whoever you want as your healthcare agent. So that includes same-sex partners, that includes non-married people, doesn't matter, right? Being married doesn't help or not help you in this situation because you can, there's a whole club of women out there that says, I'll never pick my husband as my agent. And it's not because they don't like them, it's because they don't feel like they can make some good decisions for them. So the spouse is out of the picture, and usually people will pick someone else, but the spouse will be included in the decision-making somehow. Other thoughts, questions? Okay, well, we'll just keep going. Really great questions. Thank you, everyone. And great sharing comments too. There's so much to know about this in, as you hit where the rubber meets the road. So we appreciate observations as well here. So if you want a healthcare proxy, it's on the Massachusetts Honoring Choices website in multiple languages. And here comes that first question. It's going to come back at us. A really great question about what if people can't choose anyone? What if you just can't? What if there's nobody to choose? We like to say here in Honoring Choices as, you know what, that's okay. No agent, no problem. It has gotten in so many people's way for not doing what we really want them to do, which is to tell us what they want for care, what they're worried about, what matters to them, what's important to them. And we can do that in this second document called a personal directive. We hope everybody can have an agent someday, but you know what? It's just not the way it's going to work here. So what we do want to do is, as you're working with people, is say, no, you don't have an agent? Okay, let's go to the personal directive. And even if you do have an agent, this is that really important second document. So we, excuse me, we look at this like a personal letter because in Massachusetts, any living will is considered personal. It's not legal, and that name is confusing. And that's why we call it at Honoring Choices a personal directive to help with that. It's like a personal letter to your agent, your families, your friends, your care providers. It's where you write down what's important to you, where you give instructions for the care that you want and don't want. Our clinicians are to use it to align to your care choices and goals. What's important to know is it's not a legal document, so it doesn't legally bind you as a provider to follow it. You don't have to follow it to the letter. But generally, the law says in Massachusetts, if you know what I want for care, then you should be doing your best to get me that. So what's been great about the personal directive, especially for people who find themselves without family and without friends, it's a great way to start a personal discussion so that at least their care providers know what they want for care. This is what this is the first page of what it looks like. This is our document. Everybody's free to use it. It's now translated in 5 languages, and we hope to keep going with that. I'm just going to skip this and go to the next one. So the way these documents work is there's an instructions page, and that always then follows very closely with the form itself. And as you see, it's pretty simple. People fill in their name and their address, and we find it's really helpful to know if there's a healthcare proxy or not, check a box. And then we start with talking to people about their personal preferences, their thoughts and beliefs. So what's important to you? You know, what things in your life make you worth living? Is it family and friends and whatever it is, and being involved? What would happen if you become ill and you're expected to recover, but it might be to a lesser extent, and people can help define what's important to them for quality of life, their values, their religious beliefs, their spiritual beliefs. And question number 4 seems to be very popular. You know, it just hones in on what I'm worried about most. What's interesting about that question is we don't always get what they're worried about is medical. We understand it's personal. It's who's going to take care of my cat if I get sick. If it's I'm not going to, I'm taking care of the person down the block who's going to watch my kids or my mother. So we get people to open up, talk about this, write it down, and also make a plan for what would happen after that. So you can see this is the questions. Number 2 there, we found this was really important, especially for people who didn't have agents, who they wanted to get a phone call that they were sick and they were in a hospital or situation, and they can write down those names. And the second part of this personal directive, which is very voluntary, by the way, you can fill out as little or as much as this if you want to, and use the back as well. But this is about your medical condition. And we find it's important to say to people, tell me what you know about your own medical illness. And we often hear things about the medications people are taking, what they like, what they don't like, if people who've treated them before. So again, this is about what's important to them. It helps us know when we can't speak to people what their preferences are. We can talk about life-sustaining treatments here, and also, people can write what they want and offer any other instructions or personal messages. They sign it. It doesn't have to be witnessed. It's not a legal document, but a personal document. What we've also found here is that our seniors particularly like this form, because if they are, say, 80 years old, pretty much managing their health, they're still considered really healthy. They're not eligible for a MOLST form in Massachusetts. So where do they write down their choices for life-sustaining treatment and what they want for care? This is the form they do it in. So they've been very excited to have this form. I'm going to just wrap up with this and stop for any more questions. But so the way this works is simple. If you can choose an agent, terrific. Then we want you to do both documents and encourage people to do both documents. The healthcare proxy chooses your agent. The personal directive tells them what's important. And if you can't choose an agent, just really, it's been so powerful to say to folks, you know what, that's okay. A lot of people can't in Massachusetts, all ages, all walks of life. Just start with the personal directive so we know what you want for care. And then step 3 is this really important piece where we're working with hundreds of care providers on, is to get these documents into your hands, so that you can start to have goals of care conversations with people and adjust, tell them, ask them, how you doing today? I'm sure you say that all the time. How are you feeling? And we want people to be able to say, here's how I'm feeling. And can we work on some current goals of care? And then what's ahead for me? What's coming down the pike? This is the biggest question we hear from seniors, is they don't have, is what they've said to us, the information they need to be able to either understand their illness or make decisions. And that may not be because people have told them, it's just they haven't been able to absorb it, assimilate it, even get worried about it. So that question of helping people understand what's ahead for them is an important one. So what's in the toolkit is, for consumers, we have a guide, a conversation guide, 5 things to talk about with your care providers. On the left side, my left side is in blue. Those are actually people's rights. We have a right to information Under the law, it actually says I can keep asking my care providers questions until I feel like I have enough adequate information to make a decision. I know our healthcare model doesn't work with that very well, but that's where they are. And then, we want to have a sense of what people's goals are, what their plan is. The whole idea is to know and honor their choices. So here are some questions people can choose. One, they can choose, usually the first one gets the whole thing started. I'd like to understand more about my healthcare. And then for you, on our website is the exact same talking points card, but we just flip the questions and then we mirror them for you. It's right on the website under having a discussion. And that's the toolkit. And again, what you can always do is to help people get these documents right into their record. I know sometimes you probably ask 2, 3, 4, 5 times, but I think we've found with having a talking process, just not asking about where's your document, but taking a couple of minutes, if you're able, to ask who's your agent and start the conversation that way. That empowers some trust, actually, as you might imagine, and that's what we hear from our providers, our care providers all the time. Okay, and that's the way to have a simple conversation. Are there questions in the chat about in the question and answers about that? I think I can actually see this. Yes. Okay, go ahead.
There's one. No, go ahead.
Many of my patients live in another state and may end up with specialty care in Massachusetts. Are any other neighboring states' forms honored in Massachusetts?
Yeah, great question. So again, I'm going to give you the general answer here. And because nothing is mandated by law around this, it's mandated but not followed up, not monitored. It can vary. But generally, healthcare proxies, right? Durable powers of attorney is for healthcare is what they're called, like in New Hampshire and Rhode Island. Those should be interchangeable because we pretty much, at least in New England, have the same law, similar law around picking a healthcare agent. So they should be interchangeable. What gets not interchangeable is the medical orders for life-sustaining treatment form, the MOLS form, because that's even though there should be some reciprocity around that, we're still working on it. We find that some providers take it and some don't. So if you have people ending up with specialty care in Massachusetts, you can have them make sure they're doing Massachusetts documents, so that to have in their medical record, so there's no question if they become incapacitated. I see another question.
Yes, my hospital uses the term proxy as a term for the line of command without a written agent who is in charge when there isn't any paperwork. So back to my question in reference to no written advance directives as far as same-sex marriage or non-married couples who don't share finances. What is the chain of command for decisions?
Oh, that's an excellent question. So I'm not sure where your hospital is, but let's hope it's in Massachusetts, because then I can talk to you about the law. So the command, the line of command, or where the law sits is, I as a patient, right, get to make my own decisions, period, anytime. And as long as I have capacity, I can appoint an agent, and the agent can be anybody I choose. That agent, under Massachusetts law, can make ordinary healthcare decisions and life-sustaining treatment healthcare decisions. If I cannot appoint an agent or don't appoint an agent while I have capacity, and now I have a sudden medical event where I no longer can make decisions for myself, the law in Massachusetts says nobody can strip those rights from me to make decisions, but I don't have the capacity to do it anymore. So we go to a guardianship proceeding, where someone steps forward to be a guardian. That guardian has to be appointed by the court. And in order to the court to understand that I need a guardian and it's going to help me, and that guardian will be able to make ordinary decisions for me, But if, as many of you may have encountered, guardians need to move to life-sustaining treatments or even sign a MOLST form, they need to go back to the court to get permission to do that. So that's our chain of command. So your hospital uses the term proxy as a term for a line of command without a written agent. I'm not sure how to speak to that. So again, we encounter this a lot, that hospitals make their own policies, use their own terms. They should absolutely be in line with Massachusetts law. And my suggestion is always the same. If you're able to go to your legal counsel and get some clarification on that, that often helps. Any other questions? I hope that answered it. Okay, well, I want to keep moving because we've got a little bit to cover here, but we take time with this toolkit because it's really simple for you to use. Everything is free and it's online. Please feel free to download it as we go. So how do we flow into a what matters most conversation? So you're working with someone who didn't do a healthcare proxy. Great, we're doing that. We're doing the personal directive, but this person has a diagnosed chronic or serious illness. So what's the next step? So we want to show you the Honor Choices Next Steps Toolkit and the Ariadne Lab Serious Illness Conversation Guides. So on our website is the Next Steps Toolkit, and this is to build on those discussions and to make sure people understand that your plan is only as good as your last conversation, that we want to be able to continue to have conversations to add and revise that plan right through your healthcare. So what you'll see on the website is we have more discussion guides around managing chronic illness and living with serious illness. They all build on each other, these discussion guides. And our providers have said they're very useful. They keep them in their offices to help them ask questions of patients. We also want to build on those documents. So again, there are those 3 next documents, and they're explained in the Next Steps Toolkit. All that information is on the website. We also have information about palliative care for those of you who are doing that. We've got some great webinars for your consumers and for you as care providers. And we offer you take a look, and we also have information about hospice care. So that's the next steps piece. It's right there for you. It's different than the Getting Started Toolkit. There's just a lot of information on the website here. We hope it's valuable. But we really want to introduce you to this wonderful tool, the Ariadne Lab Serious Illness Conversation Guides. They are a group in Massachusetts, and they've been doing a lot of evidence-based work to come up with a framework for our best communication practices. So you will be working with a care team, no doubt, and your care team will decide how it is you talk with people who have serious illness or frail patients, or in COVID, anybody who was high risk for COVID was now eligible for a serious illness conversation. So these conversations help adults know what to expect, what's coming next, so that you can reach a shared understanding about what's ahead and what treatment options are available to them. And it gives you the opportunity to learn firsthand and what matters most to people. What are they thinking? And then the last step is to document those patient choices in the EMR, and if a patient chooses in this state, in a MOLST form. So there's a lot of information about these toolkits, and everything, as I say, is free, and you can download this and look at this more in depthly as you go. But we want to give you the 7 steps. This is the conversation flow that the Serious Illness Guide uses, 1 to 7. And then on the right side, some of the patient tested questions, the actual language you can use. We know everybody's got a script. We hope that you can put this into your script or use it exactly as is, and it's useful to you that way. So step 1 is probably what you normally do, right? Is to set up a conversation with someone. So say you started a conversation with a healthcare agent conversation. This would be then your flow into, well, that's great, you chose an agent. Now let's keep talking a little bit. I want to know more about where you are. And I'd like to talk to you about what's ahead for you with your illness. And that's one way to open up this conversation. And maybe do some things in advance so that I can make sure we provide you with the best possible care. And we know that building trust is a really big part of this conversation. So to take a minute to start slowly with that, however you do it, has been proven to be really important. And always ask permission. It's the other thing that the evidence-based tools really looked at. If you check in with people and say, is this still okay? Is this how you want me to give you information, or am I giving you too much? Is it okay that we're going to talk about this? Seems to really help with that power dynamic and that trust. And then introducing the benefits about what you're going to talk about. You know, the goal today is, and you can again probably have a script for this, but if not, is to make sure that I have all the information that I need about what matters to you so that I can provide you with the care that you want and can support your family, etc. And it's been a great conversation starter. And then the number 2 step is now to take time before you start telling them about what you know to ask them what they know. What is their illness understanding? How realistic is the patient in front of you? What do they know about their own care? And just this simple question of what is your understanding now of where you are with your illness can open up a whole world. You never know what people are thinking. Typically what we understand is that people will first tell you what they're most worried about, which is a great clue to where they are. But what Ariadne Labs found is that this is a great time to actually stop and say, okay, great, we're talking about this. How much information about what's likely to be ahead for you do you want from me? Because we know that some patients want a little, some patients want a lot. And it's great, again, as a control, patient control and trust piece to ask that question. And this is the part in the conversation where we talk about prognosis. So depending on your job and how you work with your care team, this might differ for you. But what the toolkit talks about is this is where you share what your understanding is about where things are with your illness. So you've asked them to share, and now it's time for you to share. And what they offer in this tool, in this guide, is 3 different types of ways to give a prognosis: a time-based prognosis, a functional one, and an unpredictable prognosis. And again, this just depends on what your job is and how you function with this. But basically, to offer information about what you know about their care. We'll let you read through this. What we've heard is that even that 2 and 3 seem to be preferred even over 1, unless somebody's looking for that time-based prognosis. So now you've talked to them, and to always allow, as I'm sure you do for silence, and allow for the emotion. This is hard stuff, asking about what matters to you. Give them time to process, give people breaks. If you're fortunate enough to have people say, let's stop here and we'll come back and revisit, that's a great thing too. But you can also have some tools to respond to the emotion just by naming it and exploring it. And these are some examples of what they found to be really useful statements. I can see this is upsetting. Can you tell me more about those feelings? You seem surprised. Can you tell me about what you expected to hear? I know this is really hard to hear, probably is the most common. Just tell me more about what you're thinking. So those may be useful to you in your script. So number 4 is actually the most important piece of this, is what we all think, is that understanding patient goals helps restore that sense of a positive future and empowerment. So asking questions like, what are your most important goals if your healthcare worsens? You know, what's your goal for that? What's your biggest fear? What's your biggest worry about your future and your health? And again, you can hear all kinds of things here, whether it's family or money or care or being able to live longer, and helping that space to get a sense of people's fears, also what their sources of strength are. You know, what is it they've depended on when they've heard other bad news, and to get a sense of what's important to them. And also in this space, we're starting to look, again, depending on what your job is really exploring the trade-offs for them. This is the tougher part of the conversation, but the questions that have been helpful is, what situations are so bad that you just can't imagine yourself in that situation? Or if you become sicker, how much are you willing to go through for the possibility of gaining more time? And of course, exploring family, if there is family, and how much does your family know, and asking if that person, if they would like to invite family into this conversation. at some point and in the manner that they choose. So these questions have all tested as really helpful. So you've gone through this process and you now have a sense of where this person is, and it's time to summarize. So here's what I've heard you say is really important. And this is especially important in these emotional conversations to get a sense that we're on the right track, right? And keeping that in mind and what we know about your illness, you can make a recommendation. Now, if this is appropriate, this is what's been a useful piece in this process. If this is the time to say, well, hearing from what you said and what I know about your illness, here's what we recommend. And that becomes part of their treatment and care plan as well. But checking if that's the plan that seems right to them. Always checking, right? And then affirming that you'll do everything you can for them. That's the Ariadne Lab setup for this. And then we close by, excuse me, documenting the conversation. Anyway, that's normal for you, certainly in the medical record. And this is where we can look at the forms, the MOLS form, and we'll look at that in a minute. And then one of the things that they recommend is to make sure we're documenting in the form of communicating it to the next clinician. So if there's a specialist, if there's someone involved, whatever your system is, to make sure that this conversation you've had, which is incredibly valuable, is not lost. It is communicated to the next clinician. And again, then we come back to the documenting the conversation, and this is where our forms come back in as well. If there isn't a healthcare proxy or a personal directive, this is the time to talk about it. This may be the time to talk about a DNR or a MOLS form, mostly for folks. I'm going to just stop and see if there are questions about that. That's a lot of information for you.
I don't see any questions. Ellen, does anybody have any questions?
Okay. And so that's a lot of information, but what's wonderful about the Ariadne Labs toolkits, that's just an introduction. You can go and explore, just put it on your desktop, have it in your back pocket, use questions as you think they'll come up for you. They're free for you to use. So we just want to show you the MOLS form. For those of you who don't use it or do use it, there's always a lot of questions about this form. But we know it's basically it is made for seriously ill, frail patients, right? Where a clinician and a patient review the prognosis, the care goals, and the treatment options. Again, it follows the Ariadne Labs tool conversation. And then the patients choose, based on recommendations from the provider, A, B, and C, right? Do I want CPR, ventilation? Do I want to transfer to a hospital? And we have to remember that that's patient choice. But unless we're doing a conversation, a really good conversation, this form doesn't mean a lot to people. It becomes a checklist. We have to give them that information for them to actually make those choices that they feel good about. We know in Massachusetts, physicians, nurse practitioners, physicians assistants can fill out this form, but we're hoping as we move forward to involve more of care teams in this conversation and to be able to start conversations and have the team just work on it as a whole. So the clinician and patient sign the form, and everyone is to honor that. Every licensed provider honors that, right? So what I want to tell you, in Massachusetts, we are actually moving, this is hot off the press news, the state is moving from a most paper-based form, this one, to a pulsed form and electronic registry. So we're going to up our game a little bit. And you'll see a lot more about this. It won't happen probably till the end of the year, but I want to make you aware of it. We're going to use and adapt the national pulsed form. We are working with a national group, the 47 states, who are doing this work together to try to get to the best practices, the best tools and standards. And we're going to bring that into the state now. The state is underway thinking about it and planning it. You'll be hearing more from us. If you are not an Honoring Choices partner, we invite you all to be. Just send me an email. It's free. We want to get you at least on our newsletter. I promise it's not cumbersome. It's full of news, real news every month. And it will tell you about the new Pulse form, how your group can learn about it, how we're going to do listening sessions with everyone to give you that information, because it's so important we get your feedback. How is this working? What are the problems? We know there's a lot when it comes to MOLS. And how do we need to change that? If we bring a new form into the state and a new registry, so that we can actually download that form and retrieve it much quicker for patient care, what is it that you need in your organization to operationalize this? So please just feel free to send me an email. I'm Ellen DiPaola, and I'm on Honoring Choices, Massachusetts, and my name's all over the website. So, and let's get you connected to this so that you have that information going forward. Do I see a question?
Yes. Can a most form be completed over the phone with a healthcare agent, or does it have to be done in person?
Yeah, great question. So here's what we know, that during COVID, Honoring Choices asked the state to allow verbal consent on a most form over the phone, because we couldn't see anybody, we couldn't get to folks. So if you go to the Honoring Choices website and under resources at the top, look under serious illness and MOLS challenge, you'll see the information on verbal consent on a MOLS form. So you can call someone up and you can you do it over the phone, and there is there is a way to do electronic signatures by joining the Massachusetts eMost web portal. Let me just tell you what that is. Let me get there. So the Massachusetts eMost web portal was put together by our three organizations, the Massachusetts Coalition for Serious Illness Care, Ariadne Labs, and Honoring Choices. Again, this happened during COVID for the very reason that you're asking this question. We couldn't see people in person to be able to get signatures in person. So we asked the state for verbal consent. We created this web portal to make it easy. The web portal information is on the website. It's a link. You sign up for it, and it's a link that you can use. There's an electronic MOLS form on it right now, and you can do that through telehealth. So while this web portal is still in existence, it will be until we transfer to a registry. It's one way for you to do digital signatures as well, so that you have completed MOLS forms. I just want to, and I guess this is what I want to show you, right? So if you just go to the website, you'll see a whole page on this, and it will show you all about what this is and give you lots of videos to actually do this yourself. You can sign up for the portal, it's free, if you have a need to do those electronic forms today. Do I see a question?
It looks more like a comment. It says address the backside. Oh, the backside of the MOLS form.
Oh, yeah. Well, now I'm not sure what that question would be. There is a backside to the MOLS form. So how it works now is, as you know, the front side and the backside can work independently. You have to sign the front side to know what people's choices are. And then the backside you do independently. And the way it's supposed to work is the front side of the MOLS form is this emergency order. It's for EMTs and for people in critical care to know right away what people's choices are. The backside of the form was put there so that we can have more conversations for people about their choices for care. But it's supposed to be kind of when you get to the hospital, when you get to the nursing facility, so there's more information for the team about what people want for care. You can do either, you don't have to do the backside of this form. Some people do, some people don't. And as I say, the pages operate independently. Other questions? I want to be watchful of my time here. So please take a look at the web portal if you'd like to. As we get a new Pulse form, which stands for Portable Orders for Life-Sustaining Treatment, we will tell you more about it. We'll tell you more about the registry. I don't expect anything to happen till the end of the year, so we have some time. And that's pretty much it. That's how we have seamless planning conversations. We gave you the Getting Started Toolkit to start simply, and some other tools, including the Next Steps Toolkit and the Ariadne Labs Toolkit to really build on those conversations over time. Everything's on the Honor Choices website. If you'd like to ask me a question or come join us as a partner, we have, hundreds and thousands of care providers who take our tools and use them and just put them into play wherever they are. So thank you so much. I don't know if there's any final questions. We're here for you. I don't see any, but we're happy to take any. And if not, I just want to thank you all for listening. I hope this has been useful to you and look forward to keep working together.